Good afternoon. This is Tim Markle. I'm director of the Southern Regional Center for Children and Youth with Special Healthcare Needs out of the WISADDS Center. This is Conversations Aren't Showing Up for Kids, a nice informal space where we bring topics that are interesting to families or needed for families to think about. And we just have a nice conversation about them. A couple reminders is that we are being recorded, and so please avoid the use of any personal identifiable health information or anything else that you don't want recorded and out on the internet forever and ever and ever. Also, I am not a physician, I am not a lawyer, so please do not take anything on this show as medical or legal advice. That being said, I cannot tell you how excited I am to be joined by Maureen, Durkin, and Angelica Salinas. They are part of my WISADDS family at the WISADDS Center, and they work with a program called WISADDS, WISADDS. And so because of the fact that I live in the world of acronyms, and I feel like I swim in acronym soup sometimes, what does WISADDS stand for, and what do you guys do? And please feel free to introduce yourself with however you would like to introduce yourselves as you answer questions. So what's WISADDS?
Well, Angelica, do you want to take that?
Sure. So WISADDS stands for Wisconsin Surveillance of Autism and Other Developmental Disabilities System. So it's a program that is funded through the CDC and is a part of the larger ADAM network. ADAM stands for, I'm going to throw all these acronyms at you, Autism and Developmental Disabilities Monitoring Network. And we are one of 10 sites that is funded to conduct surveillance of children with autism.
And Angelica was good at you. Did Tim want you to, you want us to introduce ourselves?
Yeah, why don't you go ahead and introduce yourself, Maureen?
I was going to introduce Angelica and just.
Oh, well, that'd be great. This will be great. Yes, you introduce Angelica, then Angelica can introduce me. I'll introduce the mom on the line. The mom can introduce me. It's going to be so much fun.
Angelica is the project coordinator for WISADDS. Yeah, she's the one that really makes this happen, the most important part of the team in my perspective.
So then where do you fit into the team?
She's also a Wisconsin mom and many more things. And my name, I'll introduce myself, Angelica. That's not cool. I'll just say that my name's Maureen Durkin, and I'm an epidemiologist. And at the WISADDS Center, my role is mainly to help understand the prevalence of the rates of developmental disabilities in the populations that we serve. And we can talk more about what that means. Unlike Tim, I don't think I love acronyms, but they are helpful because it's such a mouthful to say the whole thing. The other thing is that about the WISADDS, or the Wisconsin Surveillance of Autism and Developmental Disabilities, sometimes that word surveillance, people wonder about, gee, does that mean I'm under surveillance? Are they spying? And I know that's not true. When we talk about surveillance, public health surveillance, we're really talking at the population level. Just it's keeping an eye on whether the rates of the frequency of the condition is increasing or decreasing, and what the outcomes are like, and what the situation is at a population level for people, in this case with autism spectrum disorders in our population. Are they being served well? You know, are the numbers going up? Are they going down? That sort of thing, so that we can plan and make sure that we're responding appropriately. That's the purpose of it.
So a word that comes up quite often as we talk about surveillance and especially autism, it seems everybody wants to know what the latest prevalence rate is, what the prevalence data is. And I don't think a lot of people understand exactly what, I know sometimes I get confused about what do we mean by the prevalence? What is the data telling us? Like right now, I think someone would say the prevalence is 1 in 60. What does that mean?
Sure, I could try that one. Really, it's really the proportion of people in the population, and it can be expressed, in this case in Wisconsin, 1 in 60 means 1 out of every 68-year-old children meets criteria for an autism spectrum disorder. You could also phrase that instead of 1 in 60, you can phrase it as a percentage. When we first started monitoring the prevalence of autism in Wisconsin, it was per 1,000. We weren't talking about percent because it was only about 2 or 3 per 1,000 that we thought.
Wow.
But then the more that we started monitoring, how frequent is it? What proportion of children have this condition? We could see every year that we studied it, it goes up. And now it's in the percentages rather than the per 1,000. And our most recent published data have us at 1.7% of children in the state having an autism spectrum disorder. And like I said, this is the same as saying 1 in 60.
Okay, and I know that what you're surveilling is those 8-year-olds. So have you figured out over doing this that as we say 1 in 60, we know it's 1 in 60 8-year-olds. Is that able to be generalized then to the population? Are we pretty sure that that then is 1 in 60 children?
Well, it's not exactly because the prevalence isn't the same at every age necessarily. Part of this is that, I mean, you'd think it should be because autism is pretty much a lifelong disability. And so, but it's often not identified until age 8. And so the reason we work with the Center for Disease Control and Prevention on this, and they chose the age of 8 because of findings that very often children with autism aren't identified. There's no record of them having autism until later than it should be. And by age 8, most of the children who are going to have a diagnosis will have one. And so that's why we do that age. But no, we are also monitoring the prevalence in 4-year-old children. And it's usually, we find it to be less than what it is in 8-year-olds. And there are something we call cohort effects, so that children who are, 16 or 18 years old now, when they were 8, the prevalence of autism was lower because it keeps going up every year. So if they might have autism that wasn't identified, the rates may be lower that we can identify in older children than at age 8.
So let's talk a little bit about identification of autism, especially as it relates to different population groups. It strikes me that as a neurological disorder, that there shouldn't be too much differences between different races or even genders, but yet there are in the reporting of the data. What are you guys finding in the data that are some differences?
Sure. Well, I mean, one of the things that epidemiologists do all the time, and we're seeing this in COVID, for example, epidemiologists monitoring, they're doing surveillance of COVID. How common is it? Who's affected? And one of the things they found right early on was that it's most severe in the elderly, and children seem to have less likely to get infected and less serious outcomes. So, these things can be differences by age, by gender, by different groups can be really meaningful. And so we look for those differences, and then we try to see what might have caused it. Now, in autism, one of the most striking findings anywhere in the world that monitors the prevalence of autism finds a much higher frequency in boys than girls, or males than females. We don't really know why this is. It doesn't seem to be an X-linked condition. We haven't really been able to explain this. There's a lot of research going on, but we do notice it. And so when you find something like this, it just like triggers a question. Okay, why is that?
Why?
And that will eventually lead us to understand better what autism is. So we look for these differences, and then it's up to other investigators to figure out what they are. Some of the other differences we've seen do relate to socioeconomic status. So over the years, children living in poverty have a lower prevalence of autism in our system. That seemed, and to us, that, you could say, well, maybe is there something about being in a wealthier family that increases your risk of autism? from what we could tell, we didn't think so. The most likely explanation has been that it's under-identified in lower income populations because they don't have access to, the Weisman Center. They might not be able to know it even exists or have a way of getting there or getting the referral. And so that finding from our surveillance data early on really was used in part to promote the idea of universal screening for autism of all children. So instead of just waiting for the knowledgeable parent who happened to know how to get the diagnosis, all children are screened for autism at regular intervals during their regular pediatric care. And we think that that's actually having a big impact. And so it's not just a diagnosis that's available to a few, it's available to all the children who need it.
So does the data seem to show that it may not be race or ethnic related, but more so to do with health equity and being able to receive healthcare at an early age and quality healthcare at an early age?
That's what it seems to be. That is what our hypothesis is at this point. It's difficult to prove and to be sure that maybe there are differences, because there are a lot of these diseases that are different in different populations around the world. But we don't have any reason to think that autism is just confined to one ethnic group or geographic area. It seems to be the more you look for it, the more we find, and it is there. It just has been the differences seem to have a lot more to do with lack of access to services. So in public health, there's a difference between inequalities, which are just differences, like actually the male-female difference. We don't know how much that is due to under-identification in girls. We don't know, or if it's just really very different frequency in boys and girls. But when we look at, so the inequality is just a difference, and then the inequity implies that there's an unfairness here, that somebody isn't having equal access to the identification, and we think that's what's the case in terms of the differences we're seeing by social class and by race and ethnicity.
So what else has the data shown? What else have we learned from, because you've been doing this for a while, as I know you guys have been collecting data for a while. Are there any other lessons learned, especially maybe around the areas of disparities?
Well, I'll mention one, and then I hope that Angelica could elaborate. But one other one is we do see a lower prevalence in rural communities than in urban. And there again, it points to, is it really less prevalent in rural areas? When you talk to people in rural areas, they don't think it's not prevalent. But the ways of identifying children through our surveillance system just aren't identifying as many in rural areas. And it probably points again to an inequity.
Yeah. And I when we think about health equity across different racial backgrounds and ethnicities, it makes me think of my own personal experience and how outreach does need to happen to Hispanic or Latinx communities and African American communities. And I like to share a little bit of my own personal story. So I had my son, who is now graduating from high school this year, but I had him at a very young age. And at that point in time, my life was very different. And so I was receiving Medicaid health insurance through the state. I was on welfare. And he was actually diagnosed when he was about 3.5 years old. And the way that happened just kind of speaks to that more needs to be done to reach families. And so a little bit about that is I was seeing somebody for my own personal health needs, and I didn't have anywhere to leave my son. And so I brought him with me to all of these appointments. And the counselor that I was seeing, she actually had done her thesis in autism. And she would write little notes on the side, and then maybe it was a few sessions in, she mentioned autism to me. I had no idea at that point in time what autism was. I had never heard of it. Um, I I didn't know what she said. My son was my first child, and so to me, that's just who he was. I didn't know, I didn't have anything to compare him to. And so um, she brought it up and she recommended that I, reach out to his pediatrician. And so I had this conversation with his pediatrician, and she had said that she had suspected that for a bit, but she was waiting to see how it played out. And to me, that just kind of blew me, like that whole thinking of suspecting but not having that conversation with me um, was so surprising, because I think, especially in Hispanic communities, we look at people in positions like a doctor as having that authority. We trust in them. We trust that they will tell us if there's things wrong. We have that respect for people, professionals higher up, whether it's teachers or doctors, whatever it is. We look at them as the expert in these cases. So when she had told me that she had suspected it but hadn't had this conversation to me, it was really upsetting to me. I was happy that we were able to get services for him at a young age, and we took him to birth to 3, and right away he received services and was put in programming and had um, help up until kindergarten. But the whole challenge of getting to a diagnosis, I think, could have been prevented had I had this conversation a lot sooner, had there been more resources, had I felt like I understood. I think now there's a lot of good things, and Tim, we were talking about that a little bit, different programs that are going out that are, getting out to especially the Hispanic community. And I think that's wonderful, because I think the more that we talk about this and we use platforms that Hispanic communities access on a daily basis, the more knowledge is spread about what autism is and what it looks like. Because I do think that we're underreporting in these communities, and that's why we're seeing this gap. And that's my own personal opinion, but
Well,
a little bit based on experience.
Trust me, I put a lot of stock into parents' personal opinions. I think they need to be listened to much more than they currently are. There's some doctors that are doing a great job with that. But in your case, as a first-time mom, there really was this reliance on the professionals to let you know whether your child was progressing in a way that was no big deal. This is how every kid does it, versus we may want to look at this. And 3.5 does seem like a long time to go for a pediatrician to think there might be something without mentioning anything. I could see where you would be very surprised by that, maybe taken a little bit off guard. Can you think of any, how would you have preferred the pediatrician handle that when they first noticed it? How should they approach a parent? What would have worked better for you?
Um, for me, I think just a very direct approach. I feel like because I looked to the doctor as the expert that would let me know if they thought anything was, out of sorts with my child at the time. I think some kind of information packet that talked to me about what autism was, or that shared concerns that, I know CDC has their milestone app out now. So there's been a lot of improvement since my son was 3.5 years old, and there's a lot more resources available. And I think autism as a whole is better understood now than it was back then. But just a very direct approach. I think that I have always been, my son is my son, and regardless of what they told me, my feelings for him weren't going to change. And I think I would have felt valued as a participant in my child's development at that time. And that the pediatrician cared for, the outcomes of my child and his development. And when you hear later on that it's something they were concerned about, you feel kind of like, is this relationship that I thought I had with my doctor one-sided, you know, like, is there not that same
Right.
mutual respect? I don't know. I've always preferred a very direct approach with whatever the topic was. It's just, you know,
And you are not alone in wanting that approach, especially from the families that I talk to have children with
right.
special health care needs. And I've heard stories from, I was just talking to a mom the other day about how, because of the early missteps by the medical community, she has a couple of kiddos with autism. And the only reason she takes them to the pediatrician is for bumps and bruises, because she feels so distrustful of them helping her with the developmental disability. And there's a lot of help that could be had, but if you cut off that relationship because you don't speak up as a professional, there could be some consequences down the road. So I'm glad that you were able to stick with your physician there.
Yes, yes.
And I do know that we have a couple people on the line with us, and I also know enough about both of them that they might have questions, but more importantly, they both live in rural communities. So I know, Maureen, you had touched a little bit on what we're seeing with rural communities. Is there anything else that we're seeing from the surveillance data or your follow-up work, or just this whole area of autism surveillance and prevalence that you think would be applicable to the rural areas?
Well, I think that, you know, it's just really been a lack of information about it. If you look at the autism research, the people who participate in studies, it's almost entire, it has been historically all highly educated, urban kind of families.
Mhm.
And there just aren't any, there's just not much research on autism in rural communities. It's difficult to do. And we're changing that a little bit, because we have another study, the study to explore early development in autism. And we were awarded that in part because we included the Marshfield Clinic in that, a big rural swath of the center of the state, on the grounds that this is the first epidemiologic study of autism to include a focus on a rural area. So I think we'll learn something. So far the patterns are the same as what they are. They're just that there are fewer that are in our surveillance. There are fewer that come to attention because they're not identified.
Well, and even that data, though, having data that confirms is really important as well, because right now we just don't know.
Yeah.
And so it's better that we know. We do have a question that, you know, looking at training providers and training on autism, and you mentioned universal screening. Do you think it's a good resource to build in, like, training daycare providers on early developmental screening?
It makes sense to me, as long as, so one of the principles of screening in public health anyway, is that you should never do it. It's unethical to screen if you don't have some follow-up. You know,
Mhm.
if you think about it, if we're going to screen for breast cancer, but there's nothing you can do, there's no place to refer you, there's no point in doing it. Same way, I think, for screening for autism. And so if the daycare center is linked in with a system where they can provide referrals, then yes, absolutely, I do. And I think, you know, listening to Angelica's experience, that you have to realize that her son is he 16 now, 18 or something? So I think things really have improved a lot in the last decade or so in terms of awareness and the training of pediatricians. I mean, it's possible that your pediatrician really didn't have training in this, or what to say to families, what to look for. They suspected, but they didn't feel maybe confident enough in it. Whereas now I think pediatricians are being trained in autism, how to recognize it, how to make referrals, what to do about it. And so, you know, it's kind of hard to fault them in the past when they didn't have that knowledge and there wasn't anywhere to send them. So I do think that we just improvements in awareness among daycare providers, among families and healthcare providers, teachers, is really, really going to eliminate some of these disparities and delays in identification that we've experienced in the past.
And I thank you so much for bringing that up. I was remiss at the beginning. I should have mentioned that we are part of this conversation is taking place in April because it is Autism Acceptance Month. A year ago, we were celebrating Autism Awareness Month. And now we are moving beyond. We hope that people are more aware, like you said, that we have progressed this awareness, and now moving to this acceptance
Interesting.
of, okay, what does this mean for our society? And starting to ask the questions about what is true inclusion? What does it really mean to include people? So thank you for reminding me that part of this is about Autism Acceptance Month. So I'm going to go ahead and sort of answer a question in the chat because, well, I started the show, so I get to. And the question is, would birth to 3 or what credentials would be referral resources, regional centers, providers? So if a daycare decides, this is my personal opinion and opinion as director of the Southern Regional Center, is that if a daycare center is going to do some developmental screening, number one, be trained on the screening tool and what it means. Make sure that you understand what you're screening for and what the results are so that you can adequately tell the parents what the results are, because it's not always as straightforward as yes or no. There's some gray area in a lot of the screeners. But then absolutely the regional centers can be a resource then to find a pediatrician, find a different diagnostician, find somewhere for that child to be diagnosed. Birth to 3, if the child's under 3, absolutely make that referral to birth to 3. Early intervention is really important. After 3, it would be a referral to the early childhood program at the local public school, as they should then go through a screening themselves from the educational angle. Can you think of other places? If, we're thinking rural places, and so there may not be that doctor that, there's probably not a diagnostic center close to them. And so I know we have some therapy providers out that can do diagnosis, but there are supports available through Birth to 3 in the regional center for those young kids. Can you think of anything else in the work that you've been doing, Angelica or Maureen, about what possible referral resources might be?
Well, I know at the Weissman Center, there's a large care integration project that is developed, and I don't know if you've had Gail Chodron on, but maybe you should invite her sometime to talk about the work they're doing to really help provide training in rural communities around and in Milwaukee, so urban and rural, but underserved communities around the state, and also providing family navigation, so trained people who can help you find that, where to get the assessment and how to follow up with referrals. So.
Well, I have some openings coming up in May, so I will reach out to Gail and we will get her on and we'll learn more about the care integration initiative. That's a great idea. I love that. I know that we're reaching close to the end of that half hour because we started a little late, but I want to give people another chance. If they have any questions, they can put them in the chat or they can unmute themselves and they can ask them. What else would you guys like to share with families today based on your work and knowledge of surveillance?
Well, one thing I would point out is another thing that we have found, I would say over the years, the gap between the prevalence in like a lower prevalence of autism found in our surveillance in children of color and in low income children, that gap has narrowed more in other states than it has in Wisconsin. We're still seeing a bit of a gap. And one of the things we've noticed is that in our state, because we review both health and school records, and one of the things we've noted is that children of color and lower income children, they're more likely to only have any indication of autism in their school record, not in their, it's not found in their health record. And in order to really, because it's a very rigorous surveillance protocol, we have to show that they have met diagnostic criteria for DSM criteria for autism. And if the record is too scant, there's just not enough information there, then they might be getting autism services, but we don't have enough information in the record. And so to me, that suggests that there's a disparity in quality of services, and schools are doing better than the healthcare system in serving underserved communities, I think. But then, of course, they're under-resourced as well for this. Another thing we have found is that, we've been monitoring. One of the things we follow is not just the number of children meeting criteria for autism, but what is the age at which they were received their diagnosis or received their earliest developmental assessment. And we've been doing this for now 20 years, and we haven't seen any change in that. It's a very late age at diagnosis. It's about 5 years, 5.5 years. Is the median age when children who eventually at age 8 are found to have autism. They weren't really given that diagnosis until 5.5 years, the median. And that's, that anybody who's knowledgeable about autism services and like when is it important to intervene would say you've missed a major window of opportunity for intervention. And we just haven't made a change in that. And it's complicated. I think what's happened is we've made a lot of improvement in identifying children earlier. But at the same time, we're identifying more children later at school age. And so it just balances out, and we just that median hasn't changed at all.
And so we can expect to keep looking for different prevalence numbers as we figure out a better way to count, basically.
Yeah, exactly.
That's awesome. Now, I feel I would be remiss if I didn't ask a question that possibly only Maureen and Angelica could answer. I know that you guys don't just talk to people from Wisconsin, but that you are in touch with people doing surveillance in different states and also across the world. Are we seeing consistent numbers depending on the countries, or is that part evening out? Or are there some places that you're just never going to get a diagnosis that they're not there yet? What's it look like across the world?
We haven't seen it even out. In our country, one of the striking things is there's actually shown on this slide, on the information sheet here, you can see this is Colorado. And what is this last? New Jersey. This was our most recent publication. Wisconsin's right in the middle in terms of the prevalence. We have a huge variation, more than double in New Jersey compared to Colorado. That's just within this country and using identical methodology in all these sites, so we can't say it's difference in methods. But we haven't seen, this is huge variability. Most diseases don't show this much variability between states. And I think that when we go on a global scale, it's even more so. Yeah. I think what it is really is the more we look for it, the more there are resources available, the more you find. And so there are some countries internationally where the prevalence is quite high. Even when the resources are low, if you focus in on a particular area, like a community in India where there might be a lot of services, you'll find the prevalence is just in the same as it is in Wisconsin, maybe a little higher. So there's just enormous variability still. It's partly that we don't, the concept of autism is changing, and we don't have a blood test or something to tell. And there's no biomarker that says yes, case, non-case. It's partly a socially defined condition, and that our social norms, and it is Autism Acceptance Month. So, maybe we're on the verge of becoming more accepting of the differences and less labeling and stigmatizing. But this is a process, and we're not quite there yet, I would say.
Well, definitely as a father, I look forward, as a father of someone on the spectrum, I look forward to the day where acceptance and inclusion is the norm, and not the exclusion because of social behaviors. So I look forward to that day. Angelica, anything else that you would like to add to the conversation before we wrap up? And please say yes, because if not, then that was a really silly question by a facilitator.
Never a silly question. Just, there was a change to our methodology this past surveillance year. And so there'll be new reports coming out soon. And so look for those. If anybody would like a physical copy of our community reports that include all of the states that participate, reach out to us and I can get those copies to you. They're also available online if you just do a search for either WISADDS or ADAM and autism. There's exciting stuff that's going on, and I'm just very excited to be a part of all of this.
Well, I really want to thank you both for taking time out of your days to be with us. I think this is a really important topic. I think we get these reports out, but we don't really understand what they mean. And so I appreciate you taking time to help us understand more about the families behind the data and who this data is tracking and identifying. I have found this conversation to be very helpful. So thank you both so very much for being here today.
Thank you.
Yes, thank you.
And as usual, I'm just going to stop the recording, and then if you can hang on, we could talk a little bit offline. Thank you so much.